The objective of this in-service is to provide insight into the effective management of UTIs. Hi, my name is Angel McGarity Davis. I'm certified in gerontology as a registered nurse. I'm a certified dementia practitioner. I'm also a certified director of nursing and a nursing home administrator. I've been in post-acute care for over 24 years. I'm excited to be here today, and I'd like to introduce Dr. Stephen Bowman.
Hello, my name is Dr. Stephen Bowman. I'm board certified in internal medicine. I've been a medical director of several ALFs as well as skilled nursing facilities in the Tampa Bay area. Thank you, Angel.
There will be no continuing education credits given in this in-service. We're going to talk about the effective management of urinary tract infections. The objectives for today, we're going to go over the regulations and healthcare reform, quality of care, the impact of anatomy on urinary tract infections. We're going to go over the risk factors for UTIs. We're going to talk about the types of UTIs, causes and symptoms, and then total UTI management. The in-service will provide insight into the total management of UTIs. You're hearing a lot about healthcare reform and Medicare. Some of the few things that you might be hearing is the Affordable Care Act, accountable care organizations, value-based payment, and quality reporting programs. The triple aim is better health care at a lower cost.
In October of 2013, Medicare instituted penalties for 3 diagnoses: CHF, pulmonary and acute MI, hospital readmission, and reduction program. In 2014, Medicare penalties will go to 2% in adding COPD and readmission for total hips and knees. It will also add penalties to the lowest performing hospitals. Signs point to quality as healthcare payment delivery reform continues to evolve. Providers are and will be incentivized for enhanced coordination of care and for achieving critical quality goals and outcomes. By improving identification, assessment, evaluation, education, and communication, we can improve quality of care. Larger hospitals may lose more than $1 million in fines based on this system. The overall number of penalized hospitals stayed about the same from October of 2012 to 2013. It is also predicted that Medicare may also do penalties for SNFs based on readmissions.
Let's talk a little bit about quality of care and decreasing rehospitalizations, and then also one of the federal regulations, F315.
Hospitals and nursing homes are going to value-based purchasing and pay-for-performance. Hospitals are being measured on core values and hospital-acquired conditions, also known as HCAHPS, which are Hospital Consumer Assessment of Healthcare Providers and Systems. One of the measures is catheter-associated urinary tract infections. We all need to do our part to help decrease rehospitalizations and increase quality of care.
One of the federal regulations that I want to speak about is F315. This is about a resident that has urinary incontinence. A resident who enters the facility without an indwelling catheter is not catheterized unless the resident's clinical condition demonstrates that catheterization is necessary. A resident who is incontinent of bladder, with or without a catheter, receives appropriate treatment and services to prevent urinary tract infections and to restore as much normal bladder function as possible. Services are to be provided to restore and/or improve normal bladder function after removal of a catheter. These are all things that are in F315 for urinary continence.
So what is a urinary tract infection? Well, the definition of infection is when organisms capable of causing disease multiply within the body that cause a response from the body's immune defenses. A urinary tract infection is a clinical condition associated with invasion by disease-causing microorganisms of some part of the urinary tract system.
Some of the questions we ask ourselves is, how do germs get in? Where do they go? How do we protect ourselves? Hand washing, hand washing, hand washing, and then also the appropriate use of gloves.
So these germs or bacteria travel on surfaces depending on the germ or bacteria for weeks or even months. These germs enter into the orifices or openings in the body. They also can enter through wounds or breaks in the skin. They can enter through the mouth, the nose, the urethra, anus, or vagina. And the number one way to stop the chain of infection is hand washing.
You're right, Dr. Bowman. You have to remember to wash your hands before putting on gloves and after taking them off. Don't put on gloves until you are ready to begin a procedure. Touch nothing but your supplies and your resident once the gloves are on. Don't touch the garbage can, not the overbed table, not the side rail, not the privacy curtain, not the door. If you forget to do something like pulling a privacy curtain, you must remove your gloves, pull the curtain, and start over. If you're going from a dirty procedure to a clean procedure, wash hands and use clean gloves before applying any of the creams.
Infections may or may not lead to clinical disease. Urinary tract infections are a common source of bacteremia, which is bacteria in the blood. This is serious and frequently leads to hospitalizations. UTIs are one of the most common infections occurring in nursing homes, most often associated with the use of indwelling urinary catheters.
Let's talk about the anatomy and the impact on UTIs, Dr. Bowman.
The kidneys and bladder work together to make urine and remove it from your body. The kidneys filter waste products or toxins and water from the blood to form urine. The urine moves from the kidneys through little tubes called ureters into the urinary bladder, which store the urine until it's full. From the bladder, urine leaves the body through another thin tube, the urethra. After the bladder starts to empty, it normally empties all of the urine. Unlike the female reproductive system, most of the male reproductive system is located outside the body. These external structures include the penis, the scrotum, and the testicles. The glans, also called the head of the penis, is covered sometimes by a loose layer of skin called the foreskin. This is sometimes removed during a procedure called a circumcision. The opening of the urethra, or the tube that transports the urine from the bladder and also semen, is at the tip of the penis. Females have an increased risk due to a shorter path of bacteria to the bladder because they have a shorter urethra. In parallel, males as they age are at an increased risk for urinary tract infections due to decreased immune response, prostate enlargement, and incomplete emptying of the bladder.
Some of the types of urinary tract infections: uncomplicated, which is an isolated incidence of a UTI, versus complicated, more than 2 UTIs a year. Catheterized patients may warrant additional evaluation, right, Dr. Bowman?
Yes, check for an abnormal PVR or post-void volume, renal or bladder ultrasounds to rule out abnormalities such as prostate, abscess, strictures, stones, polyps, or tumors. You also may want to consider referring the patient to either a urologist or, in a female's case, a gynecologist. Some urinary tracts will be chronic due to genetic predisposition, like having a real short urethra or sites that can harbor bacteria. These chronic conditions will have to be addressed.
Types of urinary tract infections. There's upper and lower. Can you talk about them a little bit, Dr. Bowman?
Sure. The most common types of infection are lower urinary tract infections, and these are of the urethra, prostate, or bladder. Upper urinary tract would be an infection of the kidneys. Now, the upper tract infections are much more serious because they can frequently lead to the condition known as sepsis, which is bacteria in the blood which causes an overwhelming immune response. These are almost always having to be treated in the hospital, as the patient can die from sepsis quite rapidly.
Some of the causes and symptoms: improper hand washing, improper peri-care technique, procedures requiring instrumentation, bowel incontinence, sexual activity, urinary obstruction, diabetes, impaired immune response. What are some of the symptoms that you would see with a urinary tract infection, Dr. Bowman?
Well, the most common symptom that most people exhibit is one called dysuria, which really means painful or difficulty urinating. Nocturia, or getting up twice or more times at night to urinate, also can do this. Pyuria, which is excessive mucus or white blood cells, can sometimes turn the urine sort of a white milky color. Older adults may present with atypical signs such as behavior changes, confusion, loss of urinary control, or a general deterioration. Anytime a patient with dementia has altered mental status, think UTI. It is important to urgently address these symptoms that decrease the quality of life for the residents in our homes that we care so much about.
Some of the risk factors: history of urinary tract infections, incontinence and conditions that cause incontinence, urinary retention, catheters, medications such as steroids, chemotherapy drugs, history of multiple antibiotic use, any underlying diseases such as diabetes, and then also limited mobility. In nursing facilities, more than 50% of the population experience some degree of incontinence.
There are several things that also can cause increased risk for UTIs, such as underlying diseases or a comorbidity that might suppress the immune system, like cancer. Other things like diabetes, which puts sugar in the urine and makes it more likely to grow bacteria, and others. It's been shown that when patients take antibiotics to treat their urinary tract infection, it's been shown that 5 to 28% of hospital admissions are involved with an adverse drug reaction, or ADR. It is sometimes postulated that up to 82% of residents taking 6 medicines or more will develop an ADR, or adverse drug reactions. It's also taking 6 medications or more may increase the mortality rate in any patient.
Let's talk about UTI policies and procedures. The facilities need to have in place systems and procedures to ensure the following are done timely: assessment, interventions, monitoring, reviewing, and revising approaches to care. Some of the things that you would want to look at is their voiding history, medication review, patterns of intake and hydration, and their functional and cognitive abilities. Also, the type and physical assistance necessary to get to the bathroom.
So medications that you want to look at are any medication that has an anticholinergic properties. This could cause urinary retention and possible overflow incontinence. Other medications that are indicated in UTIs that could have an adverse effect are calcium channel blockers, sedatives, diuretics, and narcotics. Some other diagnoses that you want to check for would be congestive heart failure, stroke, diabetes, obesity, neurodisorders like multiple sclerosis or Parkinson's disease. These all put the patients under an increased risk for UTIs.
So in your UTI policies and procedures, the interventions need to be defined and how you're going to implement them, monitor, and revise as appropriate in accordance with your current standard of practice. Monitoring and reviewing to notice changes in condition need to be recognized, how it's to be evaluated, and then also reporting it to the practitioner and others that need to be addressed. Assessment at admission, and whenever there is a change in condition for their cognition, physical ability, and or a urinary tract infection. The nursing facility not only has to make sure that their policies and procedures and guidelines are up to the federal regulations, you can't forget the patient and the responsible party education. You must discuss residents' condition with them, their management options, the expected outcomes, recognizing complications and their causes, and what are the consequences of refusing treatment. Always remember that the residents have their rights. Patient has a right to be informed to be better able to make decisions about their health care. Quality assurance and improvement. While we are awaiting the official implementation date for QAPI, Quality Assurance, Performance Improvement in Long-Term Care, its proven ability to affect change will make it worthwhile to implement now. Before you dive into QAPI, it's important to ensure your leadership and staff understand the QAPI process before applying it to a program. The merging of quality assurance and performance improvement provides a comprehensive, data-driven, proactive approach to system changes. The goal of QAPI is to set up systems that are ongoing in the midst of staff and resident turnover. As with anything new, it is always difficult to start the process. To ensure success with the program, you must first understand how to use the QAPI process. There are some sample indicators listed on the slide. Patients started on antibiotics without clinical correlation. Number of patients with indwelling catheters without appropriate justification. Number of staff training for appropriate catheter insertion and management and specimen collection technique. These are only a few samples of what you can use in your quality assurance and improvement program.
So one of the ways of instrumenting a QAPI process is using the initials PDSA. And PDSA stands for Plan, Do, Study, and Act. So some examples of this are planning. Start a small neighborhood unit instead of in the whole facility. Ensure all correct staff, disciplines, residents, and family members are utilized. Evaluate the current system using a root analysis approach to identify any areas for improvement. Develop a goal and action plan based on the root cause analysis. Ensure the goal is data-driven and measurable, such as current number of pressure ulcers acquired in-house. The action plan should have clear steps, processes, identification of persons responsible, and the time frame. Do. Examples of this: implement the action study plan in the identified neighborhood or unit. Study. Examples: on frequent intervals, get feedback from all staff, residents, and family involved. Analyze where you are compared to the goal. Analyze what's working and what's not working. Act. Make adjustments to the program based on the study analysis. Start a new PDSA cycle with the modifications. If the analysis provided the program were successful, then plan a systematic rollout to the entire facility using a new PDS cycle.
Let's talk about the importance of proper peri-care. Purpose: cleaning the genital and anal area. We want to prevent infection, odors, and also promote comfort. Some of the tips you want to remember is remember privacy. You must pull the privacy curtain, the window curtain, and shut the door. Use universal precautions. Always work from the cleanest to the dirtiest. These are warm, moist places that germs love. Be delicate. The perineal area is easily injured. Use warm water, but not too hot. Cleanse and rinse thoroughly, and pat dry. Specifically for male peri-care, start at the urethra, pushing germs away from the opening. Clean the shaft, rinse the area, cleanse the scrotum and rinse well. Pat dry. Turn the resident on their side, clean the anal area, rinse and pat dry. The female perineal area, start with the resident on their back. Use one hand to separate the labia. Remember to start at the urethra. Use a downward motion first in the center, then on each side. Clean the anal area from the direction to the urethra to the back. Once the washcloth looks clean, you are finished. Rinse and pat dry. A little bit on catheters. Make sure you follow the regulation to a T with justification and your documentation for catheters. And always remember to secure the catheter and cover it for dignity reasons. Make sure you perform perineal care before catheter care. Use a clean washcloth and soap. Moving germs away, clean the catheter from where it enters the body, about 4 inches. Repeat as necessary using a clean washcloth. The nutrition management of UTIs. Dr. Bowman, you want to talk a few minutes about?
Sure. So the main things we look for with the nutrition management are number one, and the most important, would be hydration, which is the fluid intake of the patient. Secondly, would be what the person is taking in. And it's been shown that cranberry-containing products can play a big role in managing UTIs. How much hydration is really adequate? Adequate fluid intake is approximately 30 to 35 milliliters per kilogram per day. This method may underestimate fluid needs for an underweight resident, so we can also use this other calculation to determine specific fluid needs where 1,500 milliliters would be the minimum water intake per day, with 15 milliliters fluid per kilogram to be added for the actual weight minus 20 kilograms. Fluid needs must also be based on the patient's clinical condition. So if a patient has congestive heart failure, we don't want to overhydrate them. This will be in conjunction with the resident's physician. So in here we have an example of a 120-pound woman and how we would calculate her fluid needs for the day. So if we have 120 pounds, we then divide it by 2.2 pounds, which is the weight of a kilogram, gives us 54.5 kilograms. We multiply that by the 35 milliliters, and we get her total fluid need for the day of 1,909 milliliters. If we want to figure that out in ounces, which most of us are more familiar with, that would be 64 fluid ounces per day, as there's approximately 30 milliliters in an ounce. Always look for signs of dehydration. No specific test can be done for that except for blood tests, but the main physical signs would be dry tongue, dry mouth, sleeplessness, decreased urinary output, and drier than normal skin. Cranberry products such as UTI Stat can also play a role in the management of UTIs. UTI Stat is a proprietary protection complex of 5 key ingredients that is clinically shown in 2 studies to manage urinary tract infections. UTI Stat is also low in sugar, which is good, and low in volume, as it's only 1 ounce per serving size or 30 milliliters.
These attributes make UTI Stat a favorable option to manage urinary tract infections compared to the typical cranberry juice.
So the 5 ingredients that are contained in UTI Stat are cranberry concentrate, D-mannose, which protect the urinary tract wall from adhesion of bacteria. It also contains vitamin C and FOS, which can help manage the proliferation of harmful bacteria such as E. coli in the gut. Also, bromelain, which can help manage the body's normal inflammatory response. In the first trial, there was the efficacy of cranberry concentrate protection complex medical food in the management of UTIs was undertaken in 88 long-term care residents with a history of UTIs. The complex contained a blend of cranberry concentrate and D-mannose, which have the anti-adhesion effects, vitamin C to help maintain adequate urinary acidity, creating a less tolerable environment for E. coli, FOS to increase growth of beneficial bacteria in the colon, which can reduce E. coli growth, and bromelain to help manage the body's normal inflammatory response, all in a 1 fluid ounce serving size. Participants in this study received 1 ounce BID or twice a day. Subjects were their own controls with recurrence of UTIs of greater than 2 in the past 12 months. The results showed an amazing 92% remained symptom-free. Although not an outcome measure, empirical evidence showed reduction in the incidence of falls as reported by long-term care clinicians. There is a high rate of recurrence with UTIs. This has been shown in several studies. By 4 to 6 weeks, 50 to 70% of individuals treated for UTI will again have positive urine cultures.
UTI stat is clinically shown to manage UTIs. There was another study on the same cranberry concentrate complex medical food conducted in 23 pre- and postmenopausal female patients with a history of UTIs. Results showed that the medical food was well tolerated and safe, with 91% of the subjects remaining UTI-free over 3 months, taking doses up to 60 milliliters a day. Subjects showed better rates of UTIs than the historical data. The data have demonstrated that most women with recurrent UTIs have an average of 2 to 4 episodes annually. There were also a significant improvement in quality of life. The subjects were their own controls, and as noted, there were a high rate of reoccurrence with UTIs, with the 50 to 70% of individuals treated for a UTI will again have positive cultures within a month. This is especially impactful on facilities, as on average, urinary tract infections can cost a facility $676 per resident and account for almost 30% of hospital readmissions from long-term care facilities within 30 days. UTI stat can address 12 quality of care indicators, including falls, pain, depression, unnecessary drugs, and infection control, to name a few.
UTI stat should be implemented in high-risk residents, including those with poor fluid intake, history of urinary tract infections, catheterized or incontinent individuals, or those with urinary retention or immobility.
One of the tools Nutricia has developed to help identify residents at risk is this risk assessment tool. The UTI STAT Policies and Procedure Card details specific guidelines for administering UTI STAT. For primary or recurrent UTIs, 30 milliliters of UTI STAT BID is recommended for 4 weeks, then up to 30 milliliters BID to manage reoccurrence. For overall management of UTIs, 30 milliliters of UTI stat every day is recommended. It's important to have protocols for UTI management. Here is an example of a flow chart that can help guide you through patient's care, including the administration of UTI stat.
Here is another look at the flow chart, which includes a description of the risk factors to look for with UTI management.
To find more resources and tools to help manage UTIs in your facility, log on to the Nutricia Learning Center. Once you sign up, Nutricia will keep you up to date on future free CEUs, HCP tools, and education materials.
Research into appropriate practices to manage urinary incontinence, urinary catheterization, and urinary tract infection continues to evolve. Many recognized clinical sources on prevention and management of urinary incontinence infection and urinary catheterization.
Some of the clinical resources was APIC, NIDANA, AMDA, and also the CDC, the Centers for Disease Control. We want to thank you again, Dr. Stephen Bowman, for joining us on this educational webinar, and thank you again, Nutricia, for all your support and education for healthcare.
Thank you.